control air. Up, back up. Change the location of the laptop? Yes, I don't need that. It's already used up. I just need that to. Okay. I want to go back. Okay, so autoimmune polyendocrine candidiasis. Don't talk. Hey, sir. Okay, talking. Okay, so you have this dental problem. In case you don't have this air, then the autoreactive T cells are not going to be negatively selected. Large number of autoreactive T cells are going to be released from the thymus, which cannot be controlled by the regulatory T cell populations present in the body. Come on in, have a seat, and enjoy it. So this air is a horrible disease. They have endocrinological problems, and also they will include other tissues. Candidiasis is a very important one. Candida albicans is usually hey, you talk one more time and you will be excused, okay? Because, I mean, that's no point. So Candida albicans is usually not going to cause an infection in normal individuals with sufficient immune system, but the problem in these guys that IL-17 specific antibodies are produced. The IL-17 is neutralized, and as you know, IL-17 is required for the extracellular bacteria as well as for fungi specific immune responses. So if this is neutralized, then 100% of the Finnish population showing this rare immunodeficiency called ABC is going to show candidiasis, and it's ugly. And the dermal problems and the enamel is also damaged. That's why it's made its way to the dental force. Okay, but this kind of diseases come one after another. So all this hypothyroidism, Graves-like lack of thyroid hormone and so on. Also, the hair falls out, the skin gets really albino, type, all of these can occur. The treatment is immunosuppression. I don't know why it's not working. So this is one of the examples of these cool skin diseases, and this can really show up in the oral cavity, so you will see this eventually. Pemphigus vulgaris is a more severe form. Pemphigus polyacceus is the milder version. What happens is that the autoantibodies are formed against the proteins involved in the cell-cell tight junctions, and also the binding the cells to the basal membrane. So desmoglein specific antibodies, desmoglein 1 and desmoglein 3 are actually present, and the desmoglein 3 is associated with mucosal surfaces. Okay. So what we will see is a destruction of the structure of the skin, this type of skin diseases, and inside the mouth you also see things like that. If you stain the sections of skin with specific antibody to either complement or IgG, you will see a nice staining of the cells. That's a very intensive staining. So the structure again of the skin gets really distorted, and very strong inflammation occurs, and it's not pretty. immunosuppressive therapy. There are HLA associations for each of these diseases, okay? However, we do not ask you to memorize all these HLA associations. Each of the diseases, however, I will be showing to the people who are interested, okay? And so, HLA-DR4, that's a frequent haplotype of European origin. Pemphigus foliaceus is not as devastating. However, the skin is involved pretty much, but immunosuppressive therapy, steroids can actually improve very much this exfoliative erythroderma. So the skin peels off, and then some bleeding is involved here. You can see that. The antibodies that generate these are IgG4 type antibodies to desmoglein 1. Again, this is the major protein in the skin, and DSG3 in the mucosal surfaces. And I wonder if there is a slide on this now. In the early phase of the disease, this membrane proximal domain of the desmoglein 1, EC5 specific antibodies are produced. Later on, the antibody epitope is changed, and the antibodies appear to the EC1 and EC2 domains of desmoglein. You have the figure in your Perkman book if somebody wants to look that up. And in the late phase, the antibodies have access to the proteins that the desmoglein proteins in between the epithelial cells. Therefore, they can actually attack these surfaces, and the disease can progress. EC5 is a membrane proximal domain, which in tight junctions and tight interaction in between the cells, this is practically non-accessible.
Sir,
yeah.
To answer exam question about these lectures, do we have to remember all the antibodies and proteins of these diseases?
What you need to know about this, that this is generated by an antibody, and that it affects the interaction between the epithelial cells, and then it destroys the skin. Basically, if you want to say that this is a type 2 interaction, that's also an okay thing to say. Okay, so maybe we will ask what type of antibodies generate this, and then you will have to say that this is generated against desmoglein. However, there's only 3 chapters of basically material for the dental students, and autoimmunity is a large chunk, almost half of the material. Okay, because I think the tumor immunology is not included already in the test. Therefore, this is practically the half, and the infectious disease is the other half. So I don't know why this doesn't switch the slide. So treatment is corticosteroids, and obviously steroid treatment will have some side effects. There are other agents, immunosuppressive agents like folic acid synthesis inhibitors, methotrexate, which is also used in rheumatoid arthritis and so on. Okay, now some of the patients who are resistant to steroid, they may have plasmapheresis. Plasmapheresis removes the autoantibodies from the serum, and IVIG is also beneficial to many of the diseases. Now, after treatment with rituximab, which is a monoclonal antibody, actually this is a monoclonal antibody made in mice. So this is a chimeric monoclonal antibody. This actually improves really greatly the outcome of the disease. Rituximab is specific to CD20. CD20 is a B-cell specific marker, so this rituximab treatment kills off the B cells non-selectively. However, if the B cells are killed non-selectively, any of the autoreactive antibody-producing B cells is going to be killed as well. So that's why you decrease the number of autoantibodies and the skin looks a lot better. Okay, Sjögren's syndrome is another autoimmune disease. It's relatively frequent. Again, you don't need to know the HLA associations. In Sjögren's syndrome, you also have problems with the mucosal membranes. These patients hardly produce any saliva. That's one of the major symptoms. Also, the eyes are becoming very dry. So here are the symptoms: decreased production of tears and don't have much saliva. Dental caries is very frequent, and the salivary glands are enlarged, that is, inflamed and infiltrated with T cells. Now these diseases are associated with autoantibodies as well, so they usually have elevated levels of IgG, and this IgG is specific to these common autoantigens. These autoantigens are really present in many different autoimmune diseases. These anti-Rho and anti-LA antibodies are common in many of the antibody-driven diseases, immune complex diseases, including SLE, lupus. Okay, here are some pictures for you. So really dry mucosal surfaces, inflammation here, lack of tears will lead to abrasions and obviously a little bit of inflammation later on. And so you get other exocrine glands included. Moisture replacement therapies, non-steroid anti-inflammatory drugs are used, and if it's more severe, then you get the classical autoimmune therapies, methotrexate or azathioprine. So that's also part of many. I mean, RA, they also use this therapy. Rheumatoid arthritis patients get similar things. I think we can skip this. Sometimes you have in autoimmune diseases this whitening blue of the end of the fingers, then they turn blue, and then they become highly. Then they become reddish because of the enlargement of the small blood vessels. So this is called the Raynaud's phenomenon. So 3 phases: initial cyanosis, which the part becomes anoxic and blue and red when it's compensated. And this Beckett disease or Bechet disease, I'm not sure how the sophisticated pronunciation would be, but it is a pretty severe systemic autoimmune disease. Well, they think they have various types of autoantibodies, but they also have endothelial specific antibodies. That is, some endothelial antigens, endothelial cells are present all over the body. So if you have something as cell surface antigen reactive antibody which reacts with the endothelial cells, you will have inflammation heavily and systemically everywhere in your body. All of the cells that are going to promote inflammation, and in particular mononuclear cells, neutrophils, they might be involved, and also antibodies are. This HLA-B51 is a strongly associating HLA allele with this disease, and the B27, which makes you more vulnerable to many other diseases, will have a protective effect. Obviously, they don't 100% know what triggers the disease in the first place, but the infections and exposure to heavy metals are implicated in this. And basically, in the old days, they called this disease, and they still keep calling it the Silk Road disease, based on the prevalence of the disease is actually higher in the Asian countries, and along the Silk Road, somehow the frequency is going to decrease. So it's interesting. Now, this is what you will see. So it's a vasculitis. You will have apoptosis ulcers in the mouse. So, and the skin is involved very much all over the body. You could have the genital organs showing these ulcers as well. But this is not like an infection. This is really an autoimmune process which involves T cells as well as autoantibodies. So it seems to be a T cell driven disease in the first place. But uveitis is another very common feature of the disease. But again, the skin is involved. Now, if it's an anti-vascular antibody or immune response, if it's antibody or T cell response, in the first place, God only knows, but then if it's cardiovascular, you could have cardiac infarction, heart disease associated with this. So this is really not restricted to any part of the body, and the GI tract would be also involved. And then we get the common autoimmune diseases. Now, anemias and autoimmune hemolytic anemias would be discussed. Autoimmune hemolytic anemias develop when you will have an antigen on the erythrocytes that are recognized by antibodies. Now, once the antibody is attached, what type of effector functions would be activated? What do you think? So let's say autoantibodies attached to the surface of red blood cells. What would
then dendritic cells can get it, take it. T cells can take it.
Okay.
And
well, this is it could be a dendritic cell, but it also could be a
macrophages can take it. Yeah.
And then this macrophage can destroy the red blood cells by the phagocytosis and the destruction pathway. So then anemia could develop on the long run. Also, here, what you will have is just a direct effect of antibodies. They would be attached to the cell surface of red blood cells, would activate the complement too much for the red blood cells to actually inhibit the self-complement activation. So eventually the complement system would lyse their own red blood cells. So hemolysis would develop, and you could use basically, I mean, the mechanism how this can develop, then you will always have antibodies. Two types of antibodies could be present. One type is called the warm reactive antibodies, which will react at 37 degrees, and the other type is the cold reactive antibodies. And the cold reactive antibodies are usually induced by infection, not by simply autoantibodies, but maybe cross-reactivity could play a role. And you could have drug-induced antibodies, and the classical example of this would be the penicillin. The penicillin has this reactive beta-lactam ring, which could react with the proteins present on the red blood cell, and then covalently attach the surface of the red blood cell. In certain individuals, this penicillin red blood cell complex creates such novel antigens that would generate an immune response. After the macrophages and dendritic cells take up the complex, they present the novel antigens to T cells, they develop, that's a new antigen, and then they will promote B cell responses. So you will have high affinity antibodies reacting with the erythrocytes. Okay, symptoms: fatigue, pallor, and so on. Pulse increased, yellow color of the skin, problem with the spleen, as well as the increased bilirubin. So the liver has problem as well. And you can detect this type of antibodies by two assays. Both of them would be agglutination assays. What you will add is, if you want to detect whether there are pre-attached antibodies already present in the patient, which are already fixed on erythrocytes, you would add anti-human immunoglobulins, and then you would get a positive agglutination assay, which will prevent the red blood cells from sedimenting nicely and quickly in a test tube. So if you can detect this positive agglutination assay after adding anti-human red blood cells to the patient's blood, then it means that there were opsonizing antibodies present, which are basically autoreactive self-antibodies. If you want to know if and whether the patient has antibodies in the serum, and you're not interested in whether these are going to attach or being attached already to the red blood cells, then you can isolate the serum of the patient, mix it with the test red blood cell, and then mix it with the second antibody, and then you get an agglutination if there was some antibodies already in the patient's serum. This is an indirect Coombs test or agglutination assay, and this is a direct Coombs test or direct agglutination assay, or direct antiglobulin test. This is called the so-called DAT, and this is the IAT test, indirect antiglobulin test, direct antiglobulin test. Okay, well, this is not very interesting, except that the hemolysis, which follows this type of interactions, will induce usually cardiovascular disease and heart attack and horrible things and thrombosis. So this requires immunosuppressive therapy most definitely. You could intravenous immunoglobulin injections are also useful, and anti-CD20, just like for other antibody-driven diseases, is useful because it depletes the autoreactive B cells from the patient for quite a long time. If you don't want to do something so drastic that anti-CD20, plasmapheresis will remove much of the autoantibodies and will improve temporarily the state of the patient. Good-Pasture syndrome, patients will have antibodies directed against collagen, namely the type 4 collagen. Now you know that collagen is a triplet having this alpha helical part lined up in 3, and then the head part of type 4 collagen is further assembled into a network of collagen chains. Each one of these are triple chains. Now these are present heavily in the basal membranes, and if you don't have this, you have a problem. Now, especially in these patients, autoantibodies are produced against the basal membrane within the lungs or within the glomeruli. These are the most devastating parts. The glomeruli will have high pressure fluids circulating in tiny capillaries. If the structure of the glomeruli is not right, or if there's a chronic inflammation here, sooner or later the glomeruli will give up. Now, what you will have in Good-Pasture syndrome patients, they can have antibodies attacking the basal membranes, and infiltration of immunocytes will destroy the fine structure of the glomeruli, and sooner or later proteinuria and other unpleasant things. So glomerulonephritis is going to develop just like in the lupus patients, except that in the lupus patients they have immune complex, is not an antibody attacking a self-membrane protein, a basal membrane protein. In patients who smoke, in addition to glomerulonephritis, you will also have pulmonary hemorrhages because of the fact that the cigarette smoke is going to destroy partially the structure of the lung, and therefore these autoantibodies will have access to the deeper structure of the lung epithelium, and so they can reach actually the basal membrane and generate inflammation there. Okay, if you are not a non-smoker, the person usually shows only the glomerulonephritis symptoms and not the hemorrhages in the lung, which are induced if the guy is a smoker. Okay, again, there's some HIV predisposition. Therapy is basically the same: immunosuppression, steroids, and plasmapheresis. Graves' disease. You learn about Graves' disease in physiology, no? So this is an immunological disorder. For some reason, antibodies are formed to the TSH receptor, that is the thyroid stimulating hormone receptor. So when the antibody hits the TSH receptor, it has an agonistic effect, as if the hormone would hit it, okay? If the TSH hits the TSH receptor, then it induces the thyroid gland to produce more thyroid hormone, okay? So the same thing happens if the antibody hits the TSH receptor. It will think that this is the hormone, and even in the absence of the TSH hormone, the tyrosine, T4 and the T3 hormones will be generated continuously. What the result is, in this case, is that you have overproduction of thyroid hormones, and then you will have, unfortunately, oh, here's the picture. So you will have this hyperthyroid condition, this type of Graves' ophthalmopathy, where not only the thyroid hormone causes the fibroblasts proliferate and edemas form behind the eye, and it looks this funny, and some of the antibodies may cross-reactive eye muscle proteins and generate inflammation in there. Skin fibroblasts could be also involved, and they show all the hyperthyroid syndromes. What is there for treatment is either they use an inhibitor of thyroid peroxidase, which actually generates the preform, the precursor for the hormone, or what they do is they destroy the thyroid gland using radiation, and then they use replacement therapy for the right amount of the thyroid hormone. If an autoimmune disease is mediated by antibodies, and these are IgG type antibodies, they are very frequently transferred across the placenta. So if the mother, pregnant mother, has an autoimmune disease, like Graves' disease or any other diseases affecting like hormone receptors, like myasthenia gravis, that will show up in the baby as well. Okay, if it's very severe, then they need to do some therapy, like they need to, I don't know if they can give the serum and blood or blood transfusion to the developing fetus, but they certainly can do this after birth. If these Graves-like syndromes show up in the newborn, they can do plasmapheresis and blood transfer baby, and then he would be healthy, unless he would also develop later a disease for some reason. Myasthenia gravis is a disease when in this case, an inhibitory protein or antibody is used, is produced in the neuromuscular synapse. It acts on the acetylcholine receptors, and the acetylcholine receptors are blocked on one hand, so they interfere with the binding of acetylcholine to its receptor, and also downregulated. So once the acetylcholine hits the receptor, it's going to be internalized. So as an antagonistic antibody, it still can induce the internalization, so you will have a low number of acetylcholine receptor present to receive the acetylcholine signal, in addition to the blocking effect in many times. Okay, so internalization, degradation, this is one part, downregulation, but also you could have blocking antibodies present. So obviously the muscles are terribly weak in these patients. Immunosuppressive treatment or acetylcholine esterase inhibitors might work and a little bit decrease the symptoms, but not heal the patients. Obviously, there is HLA linkage here too. HLA-DR will make more likely that patients will develop this disease. Now, books are written about lupus, systemic erythematosus. So lupus is an immune complex disease. The problem here is that autoantigens will be recognized by autoantibodies and form large number of complexes which cannot be removed by the regular way, by complement and macrophages and erythrocytes. And the normal way of removing immune complexes is that antigens are labeled with antibodies. They will activate the classical pathway of complement, then complement C3 fragments are cleaved by enzymes that you have learned, and C3b is bound on the surface of the red blood cells. The red blood cells carry the immune complex to the spleen, where the macrophages will remove the immune complex from the red blood cells and recirculate it into the blood. Now, if you do not have enough complement, or if you have too many complexes formed, this doesn't work. So you have small complexes circulating in the blood.